Good afternoon, everyone.
Good afternoon.
Good morning, good afternoon, good evening. I hope my voice is audible to everyone.
It is.
Welcome everyone to this virtual grand round, exploring the impact and response to COVID-19 on the surgical, obstetric and anesthesia ecosystem in Sub-Saharan Africa. To begin, may I ask all of you to put yourself on mute when you join. Please also note that we are recording this session, so if you'd prefer not to be working from home. So if you see my kids wandering around, please forgive me. Today we are joined by many esteemed speakers, and they represent a large number of authors who put together the Annals of Surgery paper that inspired this webinar. Please allow me to introduce myself first. I hope you're seeing the shared screen. My name is Abebe. I'm an Ethiopian. I'm a general thoracic surgeon from Ethiopia. I'm a professor of surgery, currently working in Kigali, Rwanda, where I am the Dean and Deputy Vice Chancellor of Academic and Research Affairs at the University of Global Health Equity, or UGHE. Please let me also introduce Capo Chichi. Next slide, please. Yes, she is the medical director, currently taking a break from surgical training to serve as a program assistant for SMILE training in Francophone West Africa, and is based in Benin. She formerly worked with Mercy Ships, and she's a Lifebox Associate Surgery Fellow. Our next panelist is Dr. Mekdes Daba, who's an assistant professor of orthopedics, obstetrics and gynecology at the St. Paul's Hospital Millennium Medical College in Ethiopia. And she's the current president of the Ethiopian Society of Obstetricians and Gynecologists, or ESOG. Our next panelist is Professor Sergini Maguyen Guye. He's a professor of urology at the University Sheikh Anta Diop, Dakar, Senegal, and chair of urology at the Hospital Général de Goran Jovic, and he's the current president of the West African College of Surgeons, WACS. Our next panelist is Professor Godfrey Muguti. He occupies the professorial chair in the Department of Surgery, College of Health Sciences at the University of Zimbabwe, and he's also the clinical professor of surgery at Stanford University, USA. He's the current president of the College of Surgeons of East Central and Southern Africa, COSECSA. Our next panelist is Dr. Mary Nabukenya. She is a lecturer at the Makerere University College of Health Sciences and works as an anesthesiologist at Mulago National Referral Hospital in Uganda, and works closely in the World Federation of Societies of Anesthesiologists, WFSA. Our next panelist is Dr. Thomas Weiser. He's a general trauma surgeon and a surgical intensivist, and an associate professor of surgery at Stanford University Medical Center and consulting medical officer for Lifebox, and currently based at the University of Edinburgh. Thank you very much, panelists, for joining us today. I would also like to thank our co-sponsoring organizations. These are COSECSA, the College of Surgeons of East Central and Southern Africa, the Ethiopian Society of Obstetrics and Gynecology, Lifebox, SMILE Train, UGHE, WACS, and WFSA. Thank you very much. Thank you very much for joining us today, everyone. Please don't forget to put yourself on mute. And if you have any questions, put it in the chat box on Zoom, raise your virtual hand, or email to us at covid@lifebox.org. We will talk to the panelists for about 30 to 40 minutes, and then we will open the floor up for questions from you, the audience, and from our online audience. Let me start with a quick overview of what the current situation is COVID is in the Sub-Saharan Africa and what prompted all of us to put this paper together.
I can't connect to that. I don't have the right connection. It's at my house.
If we can all put ourselves on mute. As of the 19th of April, WHO recommended over 2.2 million COVID-19 cases globally, with more than 150,000 confirmed deaths. Community transmission in Africa is already being reported, and across Africa, there have been close to 13,892 confirmed cases and 628 confirmed deaths. The top country in terms of confirmed cases is the continent is South Africa, with over 3,034 cases and 54 confirmed deaths. While the population of Africa is generally younger than in Europe and North America, Africa has much higher rates of poverty, malnutrition, HIV, and TB. And we do not know yet how COVID-19 will behave given these factors. For surgeons, obstetricians, and anesthesiologists in Sub-Saharan Africa, the main challenges will be how to maintain emergency and elective services while preserving resources, protecting healthcare workers, and doing what we can to prevent transmission. In addition, since the pandemic hit the continent about 5 weeks ago, almost all medical and health science schools are closed. Face-to-face teaching has moved to online teaching in places where e-learning facilities are available, and most residency programs are disrupted since elective cases are canceled. Clinical teaching has unfortunately been canceled completely. Webinars, case studies, online sessions, and mentorship are already taking place in some, but not all of the teaching institutions. The authors of the Annals of Surgery paper that prompted this webinar, several of whom are in our panel, set out to consider how the skills and resources that support surgical services can best be put into use in responding to COVID-19 crisis in Sub-Saharan Africa. We have set out some clear steps in this article to guide the surgical ecosystem in Sub-Saharan Africa in responding to COVID-19, and we hope to touch upon these steps in this discussion and respond to questions you may have. Let's get started. My first question goes to all the panelists. All of the panelists helped to put together the article on perioperative preparedness in Sub-Saharan Africa during the time of COVID. I would like to ask each of you to say a few words on what you consider the role of the ecosystem, surgical, obstetric, anesthesia providers, is within the COVID-19 outbreak, and what do you think our primary challenges are? Let me start by Dr. Nina. Dr. Nina, can you hear us? You're probably on mute.
Yeah, I think I'm connected now. Thank you. Okay, greetings to all panelists, and thank you, Professor Abebe, for the introduction and leading us into this panel. It's a great pleasure for me to be here today. On the topic that have been exposed and the main questions that have been asked, for this part of the world, and I would be specific about the French Francophone West African zone, and also considering the resonance of all that's been going on, I would say that the main thing that we really need in the ecosystem of the surgical environment here would be to establish and enforce a triage system that will be really clear, so we would know how to manage essential surgeries in this pandemic. And I'll be very specific in saying that it would be surgeries that cannot be postponed. So it would be really hard to say, just say emergencies, because there may be surgeries that would soon turn into emergencies. So for me, it would be really specific to say that surgeries that cannot be postponed, to avoid just the word emergency. So that would be one thing. When it concerns the providers in this ecosystem, I think the main thing that we are all facing and throughout the Sub-Saharan
I still didn't think so.
Sorry? Okay.
Please mute yourself if you're not speaking. Please, Dr. Nina, please continue.
Okay. So the main thing that the main role of providers in this ecosystem would be to minimize the exposure of healthcare providers, as well as limit the transmission of this virus from patients to personnel. And that's where it's a bit challenging, but that's where the big job is, I would say. The main trouble, that's where it is. And that's the fight, an everyday fight that is been going on. And it can be developed, and I'm sure we will develop this. But then to follow up with all this is also to come clear on a path of the case where there is a confirmed COVID patient within the surgical system. This problem, mainly Benin right now, we do not have a critical case. We have confirmed cases. We have 54 confirmed cases, 16 that already been confirmed, and 20 that have been recovered, and a few that have still been under treatment, and one death. So based on that, in Benin particularly, because we do not have a critical case, we still need to prepare a pathway within each surgical system, anesthesia and obstetrics, to create a path where we can safely isolate a COVID-19 patient, infected patient within the surgical system. And that would be the role for me is to create a clear pathway for us to know how to handle this when it is in our environment. So that would be for the first two questions. Now, the primary challenges that we face and that resonate after talking and discussing with health professionals on ground from my side is the difficult thing is to minimize the exposure as well as to prevent the nosocomial transmission of patients to personnel. That's the main challenge that throughout West Africa we have seen as been really difficult. The second thing is managing resources, preserving and managing the resources of the emergency resources of such as the personal protective equipment and consumables. And that will be the second main thing. And the last one, another list, is the strategic repurposing of operating rooms and recovery areas and staff for managing the COVID situation. The reason behind this is that there is a limited number of operating rooms already here. To rethink of repurposing those operating rooms into a separate COVID-19 patient usage only is hard. It's not impossible, but it's really challenging to do so. And also considering the staff that is in the number of people managing this aspect, this surgical, managing the number of human resources are also limited. So how many people do we shift into the ecosystem, the surgical ecosystem, to help maintain, to help fight this is also going to be challenging. So those are the three main challenges that I will raise up on this question. Thank you.
Thank you. Thank you, Dr. Nina. Let me direct the same question to Professor Sergine. The same question.
Thank you very much, Professor Abebe. It's Professor Serene Gay. Thank you. Actually, I think the challenges are almost the same everywhere. The difference being actually the situation of the health system in each country. But for the surgical environment, we mainly have three challenges. Number one will be infrastructure. Are we ready to get important cases of patients with COVID-19 to our hospitals? Number two, that is very important, is to make sure that we can provide a quality of care, including non-COVID patients in our surgical obstetrical anesthesia system. And number two will be safety of the professionals, but to safety of the patients. For the hospital that are able to definitely have possibilities to separate those patients that are not too many in Africa, I think that it is possible to work on having an environment that will allow actually to take care of the patient with good safety. Thank you very much. and there is someone walking in the bush there and distracting me. I don't know who he is, and his phone, the man in the blue on the screen. There's a man on the screen walking outside in the bush, and unfortunately, it is distracting people. Can you just remove your video so you can work, please? You, sir, the man in the blue and black is white. Yeah.
We will inform, yes, Mr. Pitan. Yes, yes. Thank you very much, Professor. The same question goes to Professor Godfrey Muguti from COSECSA. Professor Muguti, I think you're still on mute.
Thank you, Professor Abebe, and greetings to all the panelists. So the COVID-19 pandemic has presented the biggest challenge to the delivery of surgical services across the globe in our times. In this era of the COVID-19 pandemic, it is no longer business as usual in the surgical space. And the magnitude of the problem is such that as surgeons, anesthetists, and gynecologists, we now have to plan our daily routine around the demands of COVID. As a part of the health workforce in the surgical discipline, we have to rise to the occasion alongside our colleagues to deliver to the best of our ability the twin challenges of fighting COVID-19 and continuing to deliver safe levels of surgical care to our communities. Our main challenges in meeting these objectives will be, as is mentioned before by the colleagues, limited resources in terms of manpower, personal protective equipment for frontline health workers, and other essential life-saving equipment. We also have problems with the infrastructure facilities like availability of general beds in the wards for patients who are moderately ill, high dependency units, and intensive care facilities. We'll also face challenges with carrying out diagnostic and screening tests because of the costs involved, and carrying out investigations like CT scans and other relevant tests. Our health workers on the front line will also demand remuneration that justifies working in such high-risk environments. And this obviously is a challenge to our governments. Together with all the other resources required to fight the pandemic is another major challenge, which may require governments to provide insurance for health workers in the unlikely event that they lose their lives in the course of their duties. So, in essence, all the problems and challenges that we face really hinge on the fiscal space in terms of what our governments are prepared to finance. I think I'll stop my statement there for now, Mr. Chairman.
Thank you, Professor Muguti. Thank you. Dr. Mary Nabukenya from WFSA.
Hello, everyone. I'm really happy to be here. It was such an honor to be part of the article that came out in the Annals of Surgery, because I think this is really important to help guide us during our preparations. So for anesthesia, really, because it's the surgical workforce, really, many of the challenges will probably be the same. But to start with the roles, as anesthesia, really, our purpose or our biggest role is in, well, leadership for one, within our national societies and associations. It's important for us to be engaged on the national level to help guide national efforts towards COVID-19, fighting against the COVID-19 pandemic. And so that's something that's of key importance for everyone, for every national anesthesia society, everywhere, especially in Africa. And then we need to advocate for the safety of our healthcare providers. Many a time, the politicians or the people in charge might have different priorities, and they may see different things as more important. But it's always important if there's someone that is key in this fight for the surgical ecosystem to keep pushing for these things at the national level. It's important to fight for healthcare provider safety. And as well as we need to advocate for ways and systems to be put in place so as not to forget about the other diseases. And it's not just surgery, it's, you know, all the other emergencies that come into the accident and emergency departments. Because we are really concentrating on COVID-19, we might forget about all these things. And so then the challenge that would arise is maybe we won't get too many deaths from COVID-19, but then if someone counting how many deaths we are getting from all the other forgotten diseases, the forgotten emergencies that there's no one set aside to take care of. And so that's one of the challenges that we may face as a result of this pandemic. And then, of course, the challenges that everyone has talked about, protection and safety of healthcare workers. PPE is in shortage everywhere, and so that, you know, trickles down to low resource settings. And then in my country, there's so many teams working towards fighting against COVID-19. And so there's a challenge trying to coordinate all the efforts of these different teams. Everyone's getting maybe funding or working on different aspects of the pandemic, but many times there's a lot of intersection, but there's no coordination, which will bring about wastage of resources, which are really scarce. And then, of course, there's the constant fear of the well-being, the mental health of the healthcare providers. It's something that we shouldn't forget about. I think I'll stop at this point. Thank you.
Thank you very much, Dr. Mary. Dr. Makdas was supposed to have joined us by now. I think she's having troubles joining. So I'll move on to Dr. Thomas Weiser and see what he has for us. Dr. Tom, are you around?
Yes, thank you, Dr. Abebe. It's nice to see everyone, and thank you to all the panelists for joining. You know, regarding your question, I think one of the things, and Dr. Abebe, you and I have talked about this on many occasions, that one of a signal of a very strong health system is a strong surgical and anesthetic ecosystem, in the sense that the types of things that we do day to day, that's our bread and butter, actually informs a lot of what's needed right now. The idea of a strong management system, of strong leadership, of coordination across multiple professions, of a supply chain, of the concept of having durable medical equipment such as ventilators, of pulse oximeters, and also consumable equipment, including gloves and PPE. If you think about our day-to-day lives as surgeons, obstetricians, and anesthesiologists, we do PPE every day through gowning and gloving and draping. And while the COVID pandemic is going to require a little bit of a change in practice and the types of PPE we start to employ, such as the FFP2 masks to prevent inhaled aerosolization, these concepts are not far from what we do as part of a strong surgical and anesthetic system that's well coordinated and well organized. And part of the inspiration for putting this together is really to highlight how important these processes are, not just for surgery, but for strong health systems. And obviously in every country around the world, these systems are being stressed, the supply chains are being stressed, the providers are being stressed, but people show up to work every day because they have those kind of systems in place. My biggest fear is that in places where those systems are very weak or not strong, and those practices are not well embedded, as the infrastructure starts to fall apart, we will start to see a real unraveling of many health systems. And so one of the reasons for prompting the article was really to get people to think about how we can use the powers and the knowledge that we have as providers, as surgeons, as anesthesiologists, as obstetricians, to coordinate that kind of multi-dimensional team capacities to really leverage our strengths towards facing this pandemic, because we will all be asked to put ourselves forward for this kind of work. So thank you very much.
Thank you, Dr. Thomas. I would like now to ask Professor Muguti and Professor Guye, since they are the senior leaders of two senior institutions representing WACS and COSECSA. We have all watched the pandemic unfold across Western Europe and the United States. And what have we learned and what will be different in Sub-Saharan Africa from the perspectives of your organizations? Let me also add in your opinion, is lockdown working in Africa? Let me start with Professor Muguti and then Professor Guye. Professor Muguti, I think you are still on mute.
I think that's okay now. Thank you, Professor Abebe. I will start with what we have learned as we have watched the pandemic unfold in Asia, Western Europe, and North America. What we have learned is that we should be prepared for these pandemics before there is actually a pandemic. And that is part of this exercise. When the pandemic strikes, we should have in place task forces at every level of the health system. And these task forces should speak to each other. And they should be guided by very, very strong leadership. And there should be very effective communication throughout the system so that everybody knows what is going on. And in the surgical disciplines, clinicians should work in teams so they relieve each other and give each other downtime. And in the case of the COVID pandemic, this will reduce chances of, infection of health staff and cross-infection in the event that they have to look after non-COVID patients. And every effort, like has been emphasized, should be made to ensure that health personnel looking after patients should be adequately prepared. And this can only be done if they've got adequate personal protective equipment at all times. We've also learned that activity in areas like the outpatients department should be significantly reduced, and that a lot of consultations can be done online or via telephones, and the next steps worked out from there. This reduces the exposure of both health personnel and otherwise non-COVID patients from getting the infection. We've also learned that elective non-essential surgery should be postponed wherever possible, and that arrangements should be in place to carry out emergency surgical procedures at all times. Urgent cases like malignancies, which can deteriorate over time, should find space during the COVID year for patients to undergo relevant surgical procedures. But however, these patients should be triaged in such a way that some patients who may have significant comorbidities or elderly could, in the COVID era, instead of undergoing surgery, could be given neoadjuvant therapy. We also learned that there should be COVID dedicated theaters to minimize, cross-infections, and that the discharge of patients who undergo surgery and who are COVID positive should be well planned. Now, what will be different in our region? I must say our college, the College of Surgeons of East Central and Southern Africa, which was formed in 1999, has provided a substantial contingent of surgeons who will now be available during this pandemic. Because since 1999, we've produced nearly 500 surgeons. And these are in addition to what our universities in the region produce in their university programs. Now, in our situation with the reduced resources, we either have to stop doing outpatient clinics or reduce them to very low levels so that we can preserve the critical human resource and material resources that we need so that we're in a position to cope with this pandemic. And our governments, because the salary structures are not very strong in our regions, they will have to work out ways of incentivizing health workers so they are motivated to work in this very high-risk environment. What we've seen in the region is that there have been local initiatives to produce personal protective equipment. And in my own country, technical universities are now engaged in producing personal protective equipment, sanitizers, and other facilities that we need during the COVID era. And this will go a long way to cut on the cost of providing such equipment. And also we are aware from the media that the countries that normally produce this type of equipment, these countries need this equipment for themselves, and they're even running, short of these supplies. We will also have to try and ensure that most of the surgical procedures, especially major procedures, are actually done by senior surgeons to cut on the time that is needed for these procedures in theater. And this will reduce chances of infection and also cut on essential resources. Because of the costs involved, if supplies of adequate personal protective equipment are not guaranteed, then the possibility of safe reuse of protective equipment will need to be seriously considered. And there are mechanisms of trying to do this in a reasonably safe manner. And there needs to be arrangements put in place so that health personnel who are unfortunate to become infected in the course of line of duty have the best treatment facilities possible, in the region. And lastly, as I've said before, there's a possibility, like has happened in other countries, that we'll be in a position where we lose some health manpower in the course of this pandemic. And I think governments should put in place mechanisms for effective compensation, because a lot of these people are young people who have got young families. I think I'll stop there, Mr. Chairman.
Thank you, Professor Muguti. I'm glad also to see you have addressed already one of the questions raised so far. What do we do with our cancer patients in this COVID era? Should we postpone surgeries or find a way to integrate them? I'm glad you responded that we need to find a way to treat them as much as we can now. Professor Guye?
Thank you very much for Abebe. Actually, if you consider the missions of our colleges, both West African College of Surgeons or our sister colleges in the West African sub-region, or COSECSA in Eastern Africa, because we have in West Africa too, the West African College of Physicians, Nursing, and Pharmacists. And all the colleges are being impacted by the COVID-19 pandemic, and unfortunately, the lockdown due to this pandemic will be impacting in many ways as regards to accreditation, because we do accreditation all over. We cannot move anywhere, so all the accreditation processes are being stopped. We are being impacted for the training because our residents cannot access certain part of some part in the region. The caseload is being maybe reducing, and the training activities slow down in many places. We have been impacted actually in the way we run the colleges on the day-to-day basis, meaning that now we are working remotely, and that will allow us to be maybe in touch without moving. In many places, like the headquarters of my college is in Lagos. In Lagos, everything is locked down, and for now a month, actually, less than a month, all the staff is working from home. And it's the same, I think, in many places in Africa. But hopefully we have started years ago computer-based testing for some part of our exams. And I think that now what we should learn from this COVID-19 lockdown is that all the colleges should go altogether digital, and to run our activities on the daily basis digitally. I'll run our exams maybe digitally. And unfortunately, what we cannot do is actually exposure digitally, and to the outreach program we have, that we go all over in the remote places, at least to provide services for neglected surgical conditions. So I think all the colleges will be impacted at the same as regard to training, to accreditation, to exam and certification, and how to run the colleges on the daily basis. Thank you very much.
Thank you, Professor. My next question goes to Dr. Weiser. What is Lifebox doing to pivot its work to support the safety of surgery and anesthesia within the COVID-19 response?
Thank you, Dr. Abebe. So as many of you are well aware, Lifebox is a nonprofit organization that's devoted to improving surgical and anesthetic care globally. It was founded out of the WHO Surgical Safety Checklist, and many of its founding members were involved in creating that checklist originally. One of our signature, we have a number of signature programs, but one of our initial early programs was actually the identification and distribution of a low-cost pulse oximeter to help anesthesiologists and anesthetists provide safe anesthetic care for patients undergoing anesthesia and surgery. We've now delivered over 22,000 oximeters in over 100 different countries. And as you know, measuring oxygen saturation is a key component of understanding how severe a COVID case is. So severe COVID cases have oxygen saturations below 90 percentile, especially if they're on supplemental oxygen already. And so being able to identify those patients who have low oxygenation and then being able to triage them appropriately to whether they are able to be isolated at home or in an isolation facility, whether they need to be admitted to a hospital or whether they need to be admitted to the ICU, and then how much supplemental oxygen support they may need is actually really critical. And so right now we're doing a number of things. So one is we are working through our networks. We've partnered with a number of professional societies, including COSECSA and the West African College of Surgeons, to encourage our providers. I would just ask you all, if you are joining, please mute your button, please. We can hear a lot of background noise. Thank you. We're asking our partners who've received oximeters to please get those out and to use them for clinical care. We're asking our partners and our colleagues in our networks to help support the efforts of treating COVID patients, of identifying who they are and who needs quick care. We've developed a triage tool that is now on our website, and we've done that in conjunction with the World Health Organization and ALIMA, that is focused on providing emergency support, particularly in Western Africa, around how you make decisions with respect to frontline workers who are actually at the point of care, initially receiving patients who are suspected to have COVID, how they can use an oxygen saturation and a pulse oximeter to make decisions about where those patients go. And then we've done two more things. One was help guide putting this article together that's led to this grand rounds. And then we've started to collect resources. One of the things that Professor Muguti had mentioned was this idea of recycling and disinfecting PPE. And that's been of very, very high interest, not just for Sub-Saharan Africa, but for countries around the world that are struggling with PPE. So I'm based in the UK. We have a shortage of PPE. As you probably read in the news reports, places in like Northern Italy, New York City, China, these places have all struggled with low supplies of PPE. And so there's been some very creative and innovative ways to look at how you can safely reprocess PPE. And we're involved in a number of collaboratives with material scientists, chemists, engineers, to understand what's the safest way to decontaminate PPE, particularly the FFP2 respirator masks that are so important for preventing an inhalational dose of the virus. So there's a number of things that we're doing, and obviously we're doing our best to partner with multilaterals, including places like organizations like WHO and the UN, UNICEF, et cetera, to help deliver our oximeters that we currently have into the field, into the hands of providers, so that they can start providing care for patients, particularly focused in Sub-Saharan Africa and the Indian subcontinent.
Thank you, Dr. Weiser. Now let me go to Dr. Chichi from Smile Train. What is Smile Train doing to support the partners within the COVID-19 response? If you can also expand on what Dr. Weiser said earlier about PPIs, in terms of your opinion regarding the use of PPEs during surgery in non-COVID patients.
Okay, thank you, Professor Abebe, once again for the opportunity. As you know, Smile Train is an international non-profit organization, and so that really takes care and focuses on children with cleft palate, cleft lip, and cleft palate. So majority of our patients are children, although we do not exclude the adults that we may have time to time, but majority of our patients are children. And so one of the first decisions that was made by Smile Train Africa Advisory Board on cleft treatment in face of COVID-19 is to actually postpone our surgical programs for this month, to be reviewed at the end of this month. This is also to allow to make personal surgical health professionals who are working with us to be more available to respond to COVID-19 in their various countries and various hospitals, surgical hospitals. And so aside from that, we make sure that patients without urgent conditions stay at home and do not come to the hospital. One thing that we noticed is that our program, we have one program called the Comprehensive Cleft Care, which is actually a combination of the nutritional program, the surgical program, and also the speech therapy. Having pulled down the surgical program to be postponed, we have noticed that this particular program has become a priority. And so we have decided to continue doing this through telehealth or telemedicine, as you may call it. And so we keep in touch with our patients. We keep in touch with our patients through mobile phone or internet or social media one way, if the partner can. We have to understand that in this part of the world, it can be a challenge for some patients to have a phone or to communicate with us. So when it comes to the nutrition program, we keep in touch with them and they give us feedback on the weight of the patient, of the children, and we follow up. Also for the speech therapy, we have the continuity of the follow-up of the patients who are going through the speech therapy through a treatment. Yes, who are going through the speech therapy treatment. So they go online and they continue their training, they continue their the sessions with their speech therapist. And so if they can, and as you can understand, telecommunication can be a challenge here in this part of the world, so in remote places, and as well as support them psychologically. One thing we also did, as you can call it an indirect support, is our long-term partnership with the African continent as a general. And so what we have been doing even before the COVID-19 pandemic is to support and strengthen the health and especially the surgical ecosystem health of the continent. And we do that through our medical capacity building. We offer already, even before this COVID pandemic is in place, we offer training for surgeons who are at different levels of their training to reinforce their techniques in cleft lip and palate surgery. We also offer safe anesthesia as well, training. And so most of our anesthetists right now who are facing this COVID already have some competencies that have been strengthened throughout the whole year and throughout several years. So these are sort of indirect preparation towards COVID. And also nurses are involved in this kind of training. As far as needs are concerned, we have also sent and ordered some emergency response material such as the PPEs and gloves and everything else that can be needed. We have also partnered with Lifebox to send our partners pulse oximetries to be able to face this pandemic. And we have made some resources available online for them to follow up to be able to respond to this pandemic while they are facing this pandemic. So these are some of the ways that we have come up to support our partners on ground, but it's not just limited to our partners because our partners are part of the health system. And so we support the whole country in different ways, in different places that we've done this training or we've been in contact with through the partnership with other organizations. That's how Smart Train has been able to help in this way. For the second question, I would like Professor Abebe to repeat it, please, so that I can.
Yes. What's your opinion about the use of PPEs during surgery in COVID patients?
In COVID patients?
Non-COVID patients.
Non-COVID patients. My personal opinion, with all that's going on and exchanges with health professionals that are on ground facing this pandemic, it would not be advisable in terms of resources right now to use them immediately. I think that we should prioritize those that are more in face of this, of the face of COVID-19 case patients, and that would go for anesthesia. That doesn't mean that we shouldn't give to obstetrics and surgical departments, or they shouldn't use it. They should have it as an extreme emergency, but the management of it should be taken into high consideration because they are not enough. As I'm speaking to you here, in my country, although the government is helping and the Ministry of Health is helping, but we have other organizations on ground stepping in to give a lot of donations. So we never know when it's going to come. We never know when we're going to have enough or if it's going to be sufficient. So it should be allocated to those that are really extremely in the face of this, in the face of a patient that is actually infected. For non-patients, for non-patients, for non-COVID patients, we should be, that's why I said at the beginning, the main role of the ecosystem, the surgical ecosystem, is to actually make a pathway, a clear pathway, so that we know who is infected or not. And one of the things we need to think about is to actually test more our patients pre-operatively, if possible. I know it's hard, but if possible, if we can do that, to test them pre-operatively, so we can know how to manage these resources instead of use them anyhow. We don't have enough. And it's not a matter of being in a developing country, it's everywhere. So we have to do the triage very well and manage them as we can. This is my opinion of all that has been going on. Thank you.
Thank you. Thank you, Dr. Kopa. Dr. Nabukenya, from your anesthesiologist point of view, how can healthcare staff limit their exposure and transmission to the virus? And in your professional day-to-day experience, what additional concerns do you and your colleagues have? Let's also throw in a question we received from Lizzie. In a suspect COVID-19 patients requiring emergency surgery, who do you think should be in the surgical team managing this patient?
All right, thank you very much. Sorry, I went off unceremoniously.
Dr. Nabukeni, are you there? I think we have lost Dr. Nabukeni. Dr. Nabukeni, can you hear us? I'm sure we'll find her as soon as she gets her connection back. Let me move to Dr. Magdas, who just joined us now. Dr. Magdas, as I introduced earlier, is a gynecologist and obstetrician from Ethiopia. Best manage their COVID-19 cases, knowing that obstetrics and other surgical emergencies will continue to happen, and how can they best use their OR and recovery areas. If you could also talk about your experience from ESOG.
Thank you very much, Dr. Abebe. And as we know that
Dr. Magdas, I think you're
one of the okay. Can you hear me now?
I think your connection is breaking up a bit.
Hello?
It is breaking up a bit.
Hello.
Well, I don't think the connection is kind to us as far as Dr. Magdas and Dr. Nabukeni are concerned. We will try to engage them. In the meantime, let me throw one question to Professor Muguti and Dr. Weiser. With the global supply disrupted by the pandemic, how can healthcare staff conserve PPE? Now, let me start with Professor Muguti. Professor Muguti, I think you are on mute.
No, sorry about that. Can you hear me now?
Yes, we can hear you. And those of us who joined us right now, if you could all please mute your microphones. Please continue, Professor.
Yes, so there are a number of ways we can try to minimize the use of essential resources. One is to ensure that we have the minimum number of health personnel that we need in that particular theater. That will reduce the amount of PPE that we use. And we also need to make sure that all the materials that are present in the theater are actually going to be used. Because you can always make arrangements to have people who are outside that operating theater supplying extra facilities if they are required. And like I said earlier on, if you are having a lot of problems with the new PPE, there could be ways of reusing, the PPE that is supplied. And the last point I would like to make is the fact that most major procedures should be done by senior people, because if you do that, you cut on theater time, and you also cut on the amount of resources that would be used during that surgical procedure.
Can you all please mute your microphones?
So those are the points I would raise there, Mr. Chairman.
Thank you, Professor. Dr. Weiser?
So I would echo what Professor Moguti has said. I think keeping a surgical and anesthetic team down to a bare minimum of the people that are needed. I think that requires a fair amount of sophisticated planning, particularly as Professor mentioned, having a person available outside the operating theater is something that we're not necessarily always used to, but having a dedicated runner outside of the theater to help provide resources so that you're not necessarily contaminating multiple resources when you are actually in theater performing an operation. I think having very senior people available so that the control of the airway is very smooth, that induction of anesthesia is smooth, and that a case or an operation it moves quickly from beginning to end is very important. And thus having senior people driving those cases is really essential. I think another thing to do is really around team organization. So having people who are dedicated to handling COVID patients, and this primarily falls to our anesthesia colleagues who are taking care of some of the most severely affected patients. But having a dedicated team, as we all know, the more facile you are, the more experienced you are, the easier your routine becomes. And so people who are start developing a habit, and people who are well trained will be able to more smoothly understand their PPE resources and be able to also use them most efficiently and effectively. Finally, I think that there are going to be some very creative ways. These are things that I think people on the ground are going to come up with for conserving PPE. Obviously, we know, non-disposable gowns can be used, especially if caseloads are down, using non-disposable gowns from theater on some of the ICU or the wards would be useful. Ensuring that gloves are appropriately sterile. Obviously, you don't need sterile gloves, but there are plenty of places that repurpose sterile gloves. If sterile gloves can be cleaned, even if they're not sterile, they can be used for PPE if they're appropriately cleaned. And then being able to decontaminate masks and face shields and eye shields, these are things that are being done in Europe and North America now. And I think those kind of processes should be transmitted and spread as much as we can, especially if we know that they are efficacious. We know, that the surgical ecosystem is able to do instrument reprocessing and sterilization. There's no reason why we can't use that kind of infrastructure to repurpose masks and surgical masks and FFP2 masks. So all those things I think are going to come into play with respect to conserving resources. And as you know, this is bread and butter for many providers in the African subcontinent. And so the trends, the abilities are going to be stressed, but I think that very creative solutions are going to come from your colleagues across Africa.
Thank you, Dr. Weiser. The next question goes to Professor Guye. We received a question from Bani Medigan Fagla. What do you think about government's efforts in their respective countries, especially PPEs and ventilators? Are resources reaching health providers?
Actually, I think that supply chain is a big issue in Africa, I think, and maybe mostly in Sub-Saharan Africa, since all the airports are closed, there are no flight, just cargo are allowed, and the price of consumable has increased a lot. I know that the one box of mask, 50 surgical masks, used to cost about $3 when you bought it, even to China from China. It's now costing about $30. One is now $30. And this is, and even the national supply chain, the pharmacy is buying one box of masks now 16,000 CFA, meaning about $30, $40. This is very big. The problem is as regard to the personal protective equipment is the same. So now what you have decided is what is happening in Zimbabwe or other places. I think that the government has put a fund, and all the technical universities, the engineering universities are trying now to be more creative and to be more participating. We even have the School of Engineering that are designing a kind of ventilator 70 kilometers out of Dakar. So it's that way to go. Africa should now start counting on our resources, trying to use our engineer, our manufacturers to create and to develop personal protective equipment. Now we are doing masks. Having a mask is now mandatory for anybody going to any public area or transport in Senegal. So we're doing masks from the country now. We have the kind of ventilator prototypes from the country. And I feel that we should definitely go that way. And the government is very supportive to make sure that it is being provided. And I do think that at the end, global growth should start with local expertise. And Africa especially should learn from this COVID-19 pandemic and global lockdown to start growing things from African soil. Thank you.
Thank you so much. Let me now go to Dr. Nina. We have received a question from Julie Herbert. What should the protocol be regarding COVID testing prior to theater? If time allows, should a COVID test result be available before any surgery if time allows? Doctor, I think you're muted.
Sorry, did you hear me when I was speaking?
Yes,
Hello?
we heard you very well. Yes, doctor, please continue.
Yes, Professor Abebe, would you like to please repeat, because I didn't hear it?
Yes, we received a question from Julie. What should the protocol be regarding COVID testing prior to theater? If time allows, should a COVID test result be available before any surgery?
Thank you. Thank you for the question. It's true that testing patients before surgery is an ideal, like this will be an ideal situation because this is not what's happening and this is what would prefer if we had the means to do so. But in a case where we could do it, it would be really good to focus on symptomatic patients. We may have patients that over the time may not have been showing the symptoms, but over time has shown the symptoms, and we could, if we can in time do it, I think it would be the ideal. Please note that my words are ideal. but that's not the case. The ideal, because the main thing is, like I said, the challenges that we have is protecting the health personnel. If we can actually get to that point where the testing kits are made that much available and focus on patients that are symptomatic within the surgical ecosystem or within that surgical ward, it will be really good. That's just what I was trying to emphasize on. An ideal situation, but that's also to raise the voice out that we should do more testing. Actually, it's actually important if we can to do so. So that's the point. Thank you.
Thank you very much. Dr. Nabukenia, are you with us? Unfortunately, her connection did not permit, and unfortunately, Dr. Makdas is not with us. So let me again invite Professor Muguti and Professor Guye to address this question. We received a question from Eric Irungu. In many facilities in the Sub-Saharan Africa, most surgeries, especially cesarean sections, are carried out by junior medical personnel due to lack of adequate number of specialists. Are there any specific programs specifically directed towards this cadre? Use of PPEs, especially in areas where it's not realistic to get adequate and timely testing done. If you can also talk a little bit about the disruption of academics and teaching during this COVID era in our teaching institutions. Let me start by Professor Muguti. Professor Muguti, I think you're muted.
I think that is a very important question because we know that senior specialists in our continent are mostly in the bigger centers, and the peripheral, institutions tend to be manned by more junior cadres. Unfortunately, surgery in the districts and provincial hospitals will continue.
Please.
Surgery, can I continue?
Please do.
Yeah, so surgery in the provincial and district hospitals will be done by the more junior cadres who are there. And I think the most important approach will be to treat every patient who comes to surgery as potentially COVID positive, which means the surgical staff will have to have the appropriate PPE every time they go into surgery. Because the facilities which the lady was talking about for testing before surgery are not going to be universally, available. You wanted me to answer another component?
Yes, in terms of, with regards to those undergoing surgical training, won't this disruption minimize the experience of the junior trainees?
Yes, I think this is going to be a real big challenge because, as we are all aware, there are certain benchmarks in terms of logbooks which trainees have to meet before they are allowed to sit exams. And I think this is a subject that training institutions will really have to look at to see how this can be dealt with. Whether we stick to the benchmarks that we've set for the different types of surgical procedures, or there's some way of accommodating the situation because of this unfortunate pandemic without compromising the quality of services that the graduates who come out of our programs will be able to deliver when they go into the community. Thank you.
Thank you, Professor Muguti. Professor Guye, the same question to you. This is a question submitted by SAS. With regards to those undergoing surgical training, won't this minimize the experience of the junior surgeons under training? And what's the way forward to surgical training during this epidemic?
What I said initially, actually, it's a very important question. By the way, tomorrow morning, I'm having a television conference with all the chairman and secretary of our faculties at the West African College of Surgeons, because actually it will minimize the exposure of the residents, and the problem of validation of the semester is now being considered. So what should we do? So unfortunately, we don't have maybe because the case load is still good in some countries, but in some, depending on the decision in the country to keep, like for surgery, elective surgery going on or being stopped is a big matter to consider. But anyway, I think that, as I said, we will learn from what is happening now to see how we can organize the training of our residents maybe throughout Africa, because this can last a long time. We don't know when we'll go out of this pandemic. And I think all the colleges, and it's maybe an opportunity of collaboration across the region, and maybe we're gonna consider writing to our colleagues from COSECSA, and we can see all together how we can address the issue, which is very important.
Thank you, Professor. Thank you. These are indeed challenging times for academics, and regional partnership is really called into action. We need to prevail. Let me now invite Dr. Weiser. Dr. Weiser, I'm going to ask you two questions. The first one is from Preciosa. After this lockdown, what are your advices for elective surgeries? Any guidelines? And the second question is from Radiate. Should we be strict on completely abandoning elective surgeries in our countries? How do you see the possibility of surgical procedures to be done in respective cities, separating specific to non-COVID patients?
Thank you, Dr. Abebe. So with respect to your first question about how do services that have been basically put on ice, how do we reanimate the surgical services, particularly elective services, after this is all done? And I think we don't really totally know. The one thing I would say is that we're going to develop a wealth of experience over the next many months as countries start coming out on the other side, having hit a peak and then moving beyond it. So I think we'll actually learn quite a bit from looking at the experience in East Asia, in parts of Europe where they've had a severe shutdown of all elective operations, in parts of the US as well, and then have started to move away from the pandemic response and then bringing their services online. I think we'll be able to learn from some of their experiences. Without a doubt, there will be a phased response where it starts with, maybe not, hopefully there'll be ongoing ability to provide emergency and very, very urgent care. As Dr. Capoccitti had said, we don't want to totally stop urgent cases because urgent cases become emergencies soon enough. But obviously patients with insidious cancers who may be able to be postponed will probably be the first to come back online, and then more elective cases, and that will be up to kind of individual facilities, individual ministries, individual departments on how to make that phased approach. With your second question around, should we be totally abandoning elective operations? We did discuss that a little bit earlier in this grand rounds. Truly elective cases should absolutely be stopped, and I think that's been the case. At least that's been the word I've heard from numerous colleagues throughout the Sub-Saharan African continent and elsewhere, that truly elective operations have really been postponed at the moment. As you know, many operations are actually urgent or emergencies. I would suspect that a good 40 to 50% of most operations, particularly in tertiary centers, are actually fairly urgent cases, whether they're cancer cases, whether they're extremely debilitating infections, or obviously, traumas, obstructed labor, exsanguination. So those operations represent a high proportion So, you know, how do you make those distinguishing, how do you distinguish those is still being worked out, you know, at each of the facilities. Finally, I think it was there any other part of that question, Dr. Abebe, sorry?
No, I think that was it. Should we cancel elective procedures in our countries? I think you have a...
Thank you. Thank you.
Thank you very much, Dr. Weiser. Let me now call upon Dr. Nina. We have a question from Melanie. How can telemedicine assist with PPE conservation and prevent healthcare worker exposures?
Taking it from the point of view of what smart training is doing, and I'll take it from that point of view to expand. The telemedicine is actually more in the optic of reducing the inflow of patients that do not need to come to the hospital for their own sake to protect them. That's the first thing we need to understand with telemedicine. Telemedicine will help prioritize somehow the PPEs to the main healthcare that are on ground so that they can really focus on the work that they have to do.
In the interest of time, we need to conclude. So before we wrap up, the panelists and the organizers would like to express our gratitude and support for all healthcare providers, both in Sub-Saharan Africa and around the world, as they work on the front line to tackle this pandemic. Please note that we all stand alongside you. The video and audio recording of this grand round will be available at lifebox.org within a few hours. These are unprecedented times, difficult times for all of us. As you all know, there are only very few countries, 2 or 3 countries not yet affected by this pandemic. In my opinion, not because of lack of testing. I don't think it's because of lack of patients there. So all of us stand in solidarity. We will prevail. We will survive. Thank you very much, everyone. Have a good night. Have a good day.